my travels here are supported by Servier. And we'll talk a bit about stroke prevention therapies, review new data within the past year, look at indications and high-risk populations that kind of stretch the envelope. And I'll start with just an overview to get us all on the same ground. Go through the guidelines. I had an opportunity to look closely and compare the guidelines that were updated in Canada, the US, and Europe. I really like this 2018 European Heart Rhythm Association practical guide because I find it as a clinician to be very helpful when I'm struggling with a patient that wasn't exactly the type that was enrolled in a trial, and they give guidance on areas that in clinical practice we find all the time and that we don't have randomized data on. So we'll use that as a pivot point and can discuss then topics that interest you most. I hope I have time to show you the latest and greatest data with the DOACs, and then I definitely want to cover dosing and selecting the oral anticoagulants, because now that we have multiple choices, that's really a prime issue. So this slide's not mine. I actually borrowed it from some experts in atrial fibrillation and anticoagulation at a symposium that we held in Montreal a few years ago. So what they taught me is that there are more than 1/3 Canadians who have atrial fibrillation. If you make it to age 40, your chances are about 1 in 4 of developing atrial fibrillation. Now, we've known for many, many years about the increased risk of ischemic stroke, but sometimes underappreciated is the fact that if you have atrial fibrillation and have a stroke due to AF, those strokes tend to be more severe, more likely disabling, and more likely fatal. The background rate of stroke is about 4.5% per year in a patient with atrial fibrillation, but you know that varies, and we have patients with 0 or 1 risk factors, and they may be around 1% per year, and then patients with multiple risk factors, particularly the elderly and those with a prior stroke, can be greater than 10% risk per year. There are about 16,000, actually I understand the number is inching up closer to 20,000 related strokes per year in Canada, and atrial fibrillation can be linked to about 1 in 5 of those strokes. Fortunately, here you have now 4 new choices for anticoagulation other than a vitamin K antagonist like warfarin. And so in 2010, dabigatran was introduced into the Canadian market, followed by rivaroxaban, then apixaban. Then it took a while to come north of the border, but edoxaban, which is the drug I studied in a large trial called Engage AF TIMI 48. So you have 4 different choices, and I like to make the analogy that I have 4 children, and so I can't pick amongst my children who's the best. And likewise, I think amongst these NOACs, I use them all, and I try to find the one that's best for my patient. But yes, they belong all to the same class by name, but there are some very important differences that are highlighted on this slide. You all know that 2 of them are once daily and 2 are twice daily, but then there's some other interesting differences that are worth highlighting. So bioavailability of dabigatran is low. When initially formulated, it was about 4%, but then had to be bound with tartaric acid to improve the bioavailability. Unfortunately, tartaric acid works by lowering the pH in the gut and can cause gastritis, which is one of the more common side effects with dabigatran. It's not a shared side effect with the 10A inhibitors. Rivaroxaban is the only one that has an important food-drug interaction, meaning it should be taken with a meal to get maximal absorption. If your patient takes it on an empty stomach, it's as if they're dose reducing. So that's an important point just to remind patients on rivaroxaban. Protein binding varies. It's all high for the 10A inhibitors. This is mostly of historical note. The low protein binding of dabigatran means it can be removed by dialysis, whereas the 10A inhibitors cannot. The volume of distribution is interesting. It's lowest for apixaban, highest for edoxaban. And the implications of this are that although the half-lives are relatively similar across these agents, and let's look at apixaban and edoxaban specifically because these are the 2 extremes, because edoxaban gets into the extravascular space to a higher degree, hence its higher volume of distribution, the effects in hours 16, 18, 20 are that some of the drug is coming out. We think of the fatty tissues of the extravascular space. So there's a tail of effect for edoxaban, which stretches out its anticoagulant effect out to 24 hours. And if we have time, I can show you some kinetic pharmacodynamic data showing active anticoagulant effect even at trough, 24 hours after a dose, whereas the apixaban has a much smaller volume of distribution and is a BID drug. It's flying somewhat under the radar are these drug-drug interactions, and for cytochrome P450 drugs, these are important for potential interactions with rivaroxaban and apixaban only. And so you'll see now many more data and also in various guidelines some warnings about combining strong CYP inhibitors with either rivaroxaban or apixaban. The renal elimination, I think, is an issue you know well. It's highest for dabigatran, maybe not the ideal drug for patients with severe renal insufficiency. Lowest for apixaban. The US FDA, on roughly a dozen or so patients, felt that because the renal elimination is so low that it could be used in end-stage renal dialysis. So actually in the US, there's a statement in the prescribing information that says you may use apixaban in patient on stable hemodialysis. But as we learned from a recent randomized trial presented at the AHA, there was a signal towards increased bleeding in patients on hemodialysis who received apixaban compared to warfarin. Now, this drug-drug interactions is a really tough one. This is I copied 2 pages from the 2018 EHRA practical guide. It's almost impossible to go through. You need to study it for an hour or more. And so rather than taking you through, what this guideline said in particular, I just tried to summarize it. Made a simple summary where I counted up how many times of these 17 common therapies, the advice was to avoid the use of the DOAC, specific DOAC, to reduce the dose. Were there no information, or was it okay to do so? A couple points. So edoxaban, because it came about fourth, there was more time really to do drug-drug interaction studies. And actually the precursor molecule for edoxaban was the first of the 10A inhibitors introduced into man. It just then morphed into a slightly different compound that had better bioavailability, and the development took longer of edoxaban than the others. In part, I think that was the Japanese culture, developed by a Japanese company, of being very careful, dotting all your I's, crossing all your T's, in particular focus on safety. In any case, one advantage of that is they did the most drug-drug interaction studies of any of the compounds, and you see there are only a couple where there are unknown issues with interaction, and there are 7 out of the 17 common classes it's okay to use. Apixaban, on the other hand, had the fewest drug-drug interaction studies, so there's still some work to need to be done there. I think what I take away from this is if you have a patient who has a long list of co-therapies, they're one of these, what we call now polypharmacy situations, do work with your pharmacist to review the co-medications and make sure there aren't drug-drug interactions that would lead you to either decrease the dose or maybe not use that DOAC and switch to a different one, or maybe not use a DOAC at all. Like the differences in the actual drugs themselves, there are important differences between the trials, and I'll just highlight a few. I mean, yes, they all studied patients with atrial fibrillation. Yes, they all had warfarin as a comparator arm. They had similar primary endpoints, and they were all large. But notice 2 of the trials studied 2 doses. Amongst the trials, the 3 10A inhibitors all had dose reduction, but even that was different. It was only a 25% dose reduction in the ROCKET trial, whereas Aristotle and Gage had 50% dose reduction, largely due to renal dysfunction. Notice that 21 and 25% of the patients in ROCKET and ENGAGE had dose reduction. Very few in apixaban got the 2.5 milligram dose. In fact, the database is less than 1,000 patients. So our knowledge from randomized trials about apixaban 2.5 is based on hundreds of patients, not thousands or tens of thousands of patients. One difference about ENGAGE is we designed it so that there could be dynamic dose adjustment even after randomization. So, for example, if a patient 1 year into the trial had a decline in renal function, you couldn't adjust the dose. This was permitted and encouraged because that mimics what we do in practice. Whereas, let's say in the ROCKET trial, if the patient's creatinine clearance went from 60 to 35, it didn't matter. You started with 20 milligrams, you continued that 20 milligram dose. So I think that's a bit of a disadvantage in the design of the other trials. Now, a colleague and friend of mine, Christian Ruff, who was a fellow when we embarked on the trial, wrote up a meta-analysis in The Lancet combining the 4 trials together. Here's the efficacy endpoint of stroke or systemic embolism. You can see overall a 19% reduction. The 10A inhibitors all look rather similar in their point estimates. Dabigatran, perhaps, in the RELY trial, looked a bit better, although I'll point out that formally, statistically, the heterogeneity p-value is not statistically significant. Still, I mean, by eye, it looks perhaps to have a greater effect. I will point out for the endpoint of ischemic stroke, dabigatran 150 is the only drug and dose that significantly reduced ischemic stroke relative to warfarin. And that's one niche where I prefer dabigatran to reduce ischemic stroke in a generally younger patient, normal renal function, lower bleed risk, but high risk of ischemic stroke. Secondary efficacy outcomes showed a large reduction in hemorrhagic stroke for these 4 drugs and consistent and very similar across the trial, about a 50% reduction. And I think that explains why each of the trials showed about a 10% reduction in mortality, because ICH is still a devastating, often fatal condition. And if you reduce hemorrhagic stroke, well, then you reduce death related to anticoagulation and atrial fibrillation. We know that's a major issue with warfarin. And the 4 trials, I didn't break them out, but they're all right around 0.90, like 0.88, 0.91, 0.989. I don't think there is a difference in mortality reduction because that's driven by reduction in intracranial bleeding, and those are similar across the trials. Now, here are the data for the primary safety endpoint of major bleeding. You see all the 4 trials versus warfarin, and meta-analytic result of 0.86. Now, the thing is that the statisticians would tell us, hold on, stop. What is the interaction p-value, or the p-value for heterogeneity? And here it's highly statistically significant. And the implication of this is we should not really look at a combined result because we have different qualitative types of results here. And so get rid of that combined result and analyze these trials individually, or I think one could make an argument to analyze them in pairs. So here for RELY and ROCKET, dabigatran and rivaroxaban, major bleeding for the DOAC versus warfarin was pretty similar. You see risk ratios of around 1. Whereas for apixaban and Aristotle and edoxaban and ENGAGE, there were significant reductions in major bleeding with the DOAC compared to warfarin. And so really these break out into 2 groups. And to me, this is an important result with clinical implication. If I'm very worried about bleeding, I think these data would support using apixaban or edoxaban in that patient. I showed you the results for hemorrhagic stroke. Now, intracranial hemorrhage is a broader endpoint that also includes subdural bleeding and epidural bleeding. And you see, as well as hemorrhagic transformation of an ischemic stroke, and you see more than 50% reduction and similar across the trials. Whereas on the negative side, if you will, GI bleeding tends to be increased with the DOACs. It's of borderline statistical significance, but I think it's a real effect. Why is hotly debated. It may have to do with unabsorbed drug passing through the GI tract. So I just want to spend a couple minutes talking about the recent updates to the guidelines, which have been updated in Canada, the US, and Europe in the last 2 years. You're probably most familiar with the CCS guideline. I picked out a few items to highlight. One is this use of the CHAD65 algorithm, which really results in the majority of patients with atrial fibrillation having a recommendation to receive an oral anticoagulant. So if you're 65 or older, anticoagulate. If you're younger but you have a stroke risk factor, anticoagulate. And then there are 2 small groups who do not get anticoagulation per the CCS guidelines. Those are patients who are young with no stroke risk factors, but do have arterial vascular disease, either coronary or peripheral arterial. They get aspirin, and it's only the triple no, the patient who's got none of these and whom no antithrombotics recommended. The second item, and I understand this is evolving in practice, is the recommendation in the CCS guidelines to start with a DOAC. That the experts who wrote the guidelines felt there's not a need to initially try patients on warfarin first and then have them fail, that actually the data are strong enough to just start with a DOAC. The guidelines in Canada here were updated in 2018. I understand are being rewritten anew for 2020. The 2018 guidelines had 7 updates, 3 of whom were related to anticoagulation, and we can talk a bit about cardioversion. That was a major area of update recommendations in patients who also have concomitant coronary disease and acute coronary syndrome or stenting, and then some updates on reversal, which I hope I have time to share with you, reversing the effect of NOACs. The US guidelines also went through an update in 2019. Here are the 5 items that were updated, and this include getting rid of aspirin pretty much from the US guidelines, more narrowly, and I think correctly, defining valvular heart disease as mitral stenosis, significant mitral stenosis, or a mechanical heart valve, those being 2 patient subtypes in whom a vitamin K antagonist like warfarin is still preferred and recommended over a DOAC. Like the Canadian guidelines, the US guidelines now state that DOACs are preferred over warfarin. The newer data with edoxaban finally were incorporated in the guideline, and this statement which the FDA had provided with Pixaban that may be considered in patients with stable hemodialysis. This slide is a pivot slide for my talk here. It is based on the outline of the way the 2018 European Heart Rhythm Association practical guide is set up with different topics. And I don't have time to do all 14 areas, but take a look at this list. If there's something of interest to you, I'd be happy to jump ahead to that section. And while you're thinking about what you're most interested in hearing, just want to end with one slide regarding the comparison of the various guidelines. They're actually in atrial fibrillation quite similar. This is an analysis from 2013 that showed the guidelines actually agree in these 3 different areas because the evidence base is often strong. Where there are differences between the guidelines is because there's a lack of evidence, and so we're relying on expert consensus, or there are differences in the regulatory approval of one drug or not, or how drugs are prescribed that have to do not with medical science but as much as with regulations, or some subtle differences related to the culture of medicine. So I think you could read any of these guidelines, see what the different perspectives are, but the major points would be similar. So coming back to this slide, I want to ask, are there particular areas of interest? I have some data. I want to show you the new data from 2019 and some very interesting thing about selecting the drug and the dose. So that I'll leave for the end, but I thought I would pause here and see if there are some hot button questions you want to, or areas you want to review. Don't be shy. This is your chance to probe the data.
Measuring effect?
Yeah, okay. Let's start with that. So this, I have to say, this is an area that is continuing to evolve, and that the Heart Rhythm Association really went out further than any of the other guidelines, because they're a practical guide and not a guideline per se, where they started to introduce this notion of trying to figure out just what is the level of anticoagulation that's being achieved. So this chart table comes actually from the guideline. It summarizes the pharmacokinetic data for each of the agents and says what is the expected concentration of the drug at peak and at trough. It's useful as a reference. This is what was observed in the different studies. But a couple of caveats. First of all, whose lab can actually measure these in a timely fashion? I mean, it would have to be a special research lab, and typically our hospitals aren't set up for that. So it's of interest maybe for the future, but right now not all that applicable. Second point is look at how broad these are for each of the drugs. I mean, in some cases, in many cases, the levels at trough well exceed what the expected range is at peak. So, just reporting these values is a start, but I don't think it's going to move the ball down the field all that much. I think what's more helpful here is this description about what happens with the different agents on the common anticoagulant tests that we have. The pro time is not particularly helpful. Is prolonged with each of the drugs, and it can be quite prolonged with rivaroxaban and frankly misleading. It doesn't always reflect the anticoagulant effect of that drug. For the PTT, that can be helpful for dabigatran to identify patients in whom there's quite a bit of dabigatran on board and still active. If the PTT is up above assay, you can be sure that patient still has dabigatran in the blood. The ACT, not particularly helpful. Of the common tests, the most helpful one is the thrombin time. You often have to dilute it because dabigatran's effect is so potent on that particular test. But that can actually give you an idea of how much dabigatran's around. For the 10As, you see there's nothing that's all that helpful, although many hematology labs are now have the availability to test a 10A activity, and that would be what you'd want to look at. And you have to check with your hematology lab whether they can do it. Ours can, but only during the weekdays and the work hours during the weekdays. So that's one, test that's at least available in some hospitals one could use. Community hospital, no. Community hospital, you probably only have the PTT, and that may be helpful for dabigatran, whereas the common anticoagulation tests are not so helpful. They provide some guidance on when you might consider measuring anticoagulant effect or concentrations. And I agree that these are all reasonable scenarios. It's just that it's not all that readily available. Important point made here is for the vast majority of patients, because the pharmacokinetic and pharmacodynamic profile of these drugs is so predictable, there are no measurements that are needed. Whether for unusual patients that are extremely obese or have particularly changing renal function, a single measurement might be helpful. I think conceptually it would, but that hasn't been proven yet. We were fortunate in the Engage AF study that the sponsor supported efforts to collect a lot of pharmacokinetic, pharmacodynamic data. So we have thousands and thousands of patients where we measured drug levels, peak and trough, and 10A activity using 2 different assays. This is a figure from Christian's Ruff paper in The Lancet on edoxaban dosing, concentration, and outcomes. And we found this. Here's the concentration of edoxaban at trough. And here's the probability of an event. And you see the expected curve for major bleeding, which increases as the concentration goes up, stroke or systemic embolism. And if you look just at ischemic stroke, so ischemic events go down. And intracranial hemorrhage was pretty flat. This has surprised us. So at least with this particular DOAC, you don't expose a patient to a higher risk of ICH if the levels get high, but you certainly run a risk of major bleeding. And you can see that as you push the concentration up, the trade-off is less and less favorable. Fortunately, the concentrations that were seen in the trial were in the 20 to 50 range. So at a point where the trade-off between major bleeding and ischemic events is more favorable. We also measured what I think is the best assay out now for identifying the pharmacodynamic effect of the drug. And this is the inhibition of endogenous factor 10A. In other words, not injecting activated substances that activate 10A, but actually seeing what the patient's own coagulation system can do to activate 10A, and then what happens when you give edoxaban. So you compare at baseline with no drug with after steady state on drug, and you say what's the percentage of inhibition of the patient's own factor 10A activity that occurs with edoxaban. And as far as I know, we're this is only done in the trial that I was involved in. And you can see that there's a predictable effect that is highest for the 60 milligram dose, and then this is patients who were dose reduced to 30, and then these are the patients who were in the lower dose regimen that received either 30 or 15, and it's very predictable and follows along with the doses, and the issue being that there's a fair amount of variability, as you can see from the error bars. We did also write up our experience with this in the journal Circulation 2 years ago and found this relationship between major bleeding and ischemic stroke. And now I've plotted here the actual levels seen for the 60 dose reduced to 30. The lower dose regimen is not approved for use because it doesn't protect as well from ischemic stroke. And you can see that the levels just get low with that dosing regimen. So the approved dosing of edoxaban is 60 milligrams for the majority of patients, 30 milligrams for those with renal dysfunction or low body weight. And so that sits right on this part of the curve. So that, I think, is another thing for the future, is how do we incorporate on the unusual patient some measurement of either drug concentration or drug effect. Another topic of interest here? Anybody? Yeah, that's one where we really do need more data, don't we? So let's see what I have here. These come again from the EHRA practical guide, who knows that, okay, well, you have an active GI bleeder, they're in the hospital, first thing you'll do, you'll hold anticoagulation, and then think about what other drugs may be contributing, whether it's a non-steroidal anti-inflammatory or an antiplatelet drug. And then the challenge becomes, what do you do about restarting it? And so it depends. It depends on where the site of the bleed is. If it's a high-risk situation like angiodysplasias in the small bowel, for which we really have not very good therapies, maybe your threshold to resume is higher than if it's a lesion that can be treated with an endoscopic procedure and then you're done. So you need to think about the underlying pathology there for causing the GI bleed. Is it reversible, or is it a treatable cause or not? And then other issues that maybe you could modify, like if the patient's consuming too much alcohol, or the patient's on dual antiplatelet therapy, and maybe now they could get away with one antiplatelet because they're 6 months post-stenting, for example, or they're 2 years since their stent, and maybe there's not a strong indication for aspirin at all. So consider these factors. They don't give a specific score or guidance. They say, use your clinical judgment. And then in patients in whom there's just ongoing high risk of GI bleeding, there's a minority of patients in whom we ought to consider closing the left atrial appendage and not giving them anticoagulation. I can say in Boston that this is infrequent. I have done it on exactly 2 of my patients. Personally, my threshold is quite high. Across town at the Mass General, they have a much more active cath lab that's closing the left atrial appendage. We'll see. We need to have studies to really sort this out. For the majority of the patients, though, the recommendation is to reinitiate about a week out from a GI bleed, and maybe longer if the patient has some of these high-risk features. And to note that dabigatran and rivaroxaban are 2 of the drugs that tended to have bleeding rates that were similar to warfarin. And if this patient had GI bleeding on dabigatran or rivaroxaban, consider substituting either apixaban or edoxaban that appeared to have a better bleeding profile. I think I have time for one more topic. Yes?
I'm interested in your comments on management of patients for urgent or emergency.
Yeah, sure. Very important, right? I get this call probably 2 or 3 times a week for patients. Oops, I went the wrong way. For, what do I do? I have an upcoming surgery, elective, and then the more challenging one, usually an inpatient consult. What do we do now? There's a acute aortic dissection, type A, and we need to go to the OR today. So first thing is, sorting out just what is the real level of urgency of the procedure. Is it an immediate procedure and you need to go to the OR within minutes? Is it urgent and it's more like hours instead of minutes? Or is it just you want to speed up the time to the procedure? Maybe it's a Friday and a patient comes in with unstable angina, and the cath lab's not available over the weekend, except for emergencies, and so it would be convenient to get this done on a Friday, but the patient just took their 10A inhibitor, let's say. So that's to expedite the procedure. So the practical guide says, well, check their available anticoagulation parameters. For the immediate procedure, where you've got to go to the OR no matter what, it's a life-threatening condition, then reversal of the NOAC's recommended. In Canada, that means adiracizumab, the antidote, the antibody, for dabigatran. For the 10A inhibitors, it would be the protein complex concentrates. I know in Quebec they're telling me Baraplex is what they use there. Is that the same here? Your factor concentrates. So it's, it's not vitamin K, which doesn't work for DOACs. It's not fresh frozen plasma, which has if you measure the INR of fresh frozen plasma, it's about 1.7, 1.8. But it's actually infusing back the factor concentrates that works for in the States. We have an antidote for 10A. It should be available soon, I hope, in Canada. The folks at McMaster have led the studies and show that you can reverse 10A activity with this small molecule that mimics factor 10A, and so the drug binds to the small molecule rather than actual circulating 10A. But immediate surgery, reverse the NOAC, go forward with the operation, and then follow the patient's coagulation profile afterwards, which granted is a little tough with the 10A inhibitors. Urgent surgery, which is not an uncommon situation, a broken hip that really should go to the OR soon. If you can defer for 12 to 24 hours, that would be best. If necessary, and you need to go forward, or the coagulation profile still shows you, for example, that they're on dabigatran and the dilute thrombin time is still high, the PTT's off the map, then that's a time you would reverse and go forward with surgery. If it's more elective, and it's a surgery with substantial risk of bleeding, probably the best thing is to just, let the surgeon know it's not really safe to go forward at this time and to wait. And then how long you wait depends on the risk of, the surgery. And I think I have that in a different section, but if it's a high bleeding risk surgery, you should wait 48 hours at least for the 10A inhibitors, and for dabigatran even longer, 3 to 5 days, depending on the degree of renal insufficiency. Normal renal function may be 3 days, mild to moderate 4, severe renal impairment on dabigatran, it's 5 days for the drug to wash out. So, an area that, again, we could use more data and experience, and really would be helpful, I think, here to have the 10A reversal agent available. I've used it several times in the U.S. It's quite expensive. It's $27,000 per dose in the U.S. So we actually have an entire team that evaluates the use when it's indicated to say, well, yeah, we're doing this because the patient needs urgent surgery, like an intracranial hemorrhage, and they just took a NOAC, and it's not that, the patient wants to have their knee replacement done today and not wait several days for it to be washed out. Okay, well, I think, because I want to keep on time, I'm going to jump ahead to some new data that just came forth in the latter half of 2019 and share with you what's new here. One of our interventional cardiologists is Brian Bergmark. He wrote this paper up, and he said to me, well, I'm reading these papers, and they all use this bleeding scale called ISTH. I'm an interventional cardiologist. I don't know what ISTH bleeding means, and it has some kind of lower level bleeding. He says, I know about BARC bleeding. That's what we use in coronary intervention trials. And I have an idea about what Gusto and TIMI bleeding are. And I said, Brian, you're right. I said, it's a good question. We should look at that. And why don't you analyze that and write up the paper? So that was what happens if you ask a good question in our group. So he actually published a very nice paper in Circulation. And here the most severe bleeding events at the top. So BARC 3C or 5. This means bleeding, intracranial bleeding, deep intraocular bleeding, or fatal bleeding. And then you see Gusto severe, TIMI major, etc., down to the least severe, which are basically kitchen sink type of definitions where any kind of bleeding counted. Notice first the annual event rate in the warfarin group. For the most severe is 1%, all the way up to 18%. And it mirrors that. These are data from our trial with edoxaban from 0.4 to 16%. So depending on which bleeding definition you use, you could have a widely different incidence of bleeding. And what we also showed, interestingly, was a difference in the hazard ratio. This is a hazard ratio, edoxaban versus warfarin. To the left favors edoxaban. And so what we learned here, which I hadn't anticipated, is that the most severe bleeds are the ones that are being reduced by this particular DOAC edoxaban. I haven't seen similar data with the others, but I really honestly have no reason to believe it would be different. But that's somewhat reassuring message, that it's the most serious bleeds that are being prevented with a DOAC relative to warfarin. One of our other fellows, Thomas Zellniker, was interested because he sees he has a specific interest in coronary artery disease, and so he pulled the data together from the 4 trials in patients with history of coronary artery disease. So focus on the bottom half here. This is again a meta-analysis. To the left favors the DOACs, to the right favors warfarin. You can see in patients with coronary artery disease, the DOACs are a better choice than warfarin, with a 24% reduction overall in stroke or systemic embolism. Maybe some toggling about the different drugs. Apixaban here had a hazard ratio close to 1. I try not to make too much of a deal about, a subgroup analysis and a meta-analysis. We really would like to have head-to-head trials here. Here's major bleeding, again focusing on those with prior coronary artery disease. Overall, the DOACs have a similar rate of major bleeding. Perhaps apixaban is the one, along with edoxaban, where the hazard ratio was lowest. And then here's cardiovascular death. Overall, in patients with coronary disease, you could use a DOAC and expect to have a mortality that's similar to warfarin on average. Edoxaban, for whatever reason, again had a significant reduction in cardiovascular mortality amongst the subgroup with prior CAD. I think this is a really interesting paper. I don't know if you saw this one that was published in the New England Journal just a couple of months ago, the AFIRE trial. So this is all done in Japan, and it was testing patients who had stable disease and were remote from ACS or PCI, and asked the question, can we get away with just an anticoagulant, or do we need to add in an antiplatelet in these patients? So what they did is, and all the patients had atrial fibrillation and coronary disease, stable. They took over 2,000 Japanese patients. They either had to have a revascularization, coronary revasc, more than a year ago, or stable medically managed coronary disease without prior revasc. And then in an open label fashion, they randomized them to rivaroxaban alone or rivaroxaban plus 1 antiplatelet, and for 70% it was aspirin was the 1 antiplatelet, the other 30% thienopyridine. Now you'll notice the dose of rivaroxaban is not the dose we use in North America. That's because in PK/PD studies, 15 milligrams of rivaroxaban in a Japanese patient achieves the same anticoagulant effect and concentration as 20 in a Caucasian patient, so that indeed the approved dose in Japan is 15 of Riva, dose reduced to 10. And that's what they use in this study, whereas we use 20, dose reduced to 15 for atrial fibrillation. It was open label, it's a caveat. And whereas the right-hand panel here, major bleeding, doesn't surprise us, getting rid of an antiplatelet drug has less bleeding, I think many of us were surprised to see that even the efficacy endpoint, stroke, embolism, MI, unstable angina, or death, was reduced with rivaroxaban alone. So the guidelines which are evolving now to say, if you had your MI more than a year ago, or you're well past the window for PCI that you're worried about, stent thrombosis, and generally that's a year, taken as a year, you could get by with just anticoagulant alone. And these are the data that I think help support that now. And I imagine that the next iteration of the guidelines in Canada and Europe and the US are all being done for 2020 will likely elevate this recommendation that you can get away with anticoagulant alone if you're more than a year out from stent or MI. Really important information from just west of here came out of the group from Hamilton, McMaster, who they have 2 very nice papers in late 2019 on reversal of the DOACs. So here, the Annexa 4 final report is the 10A reversal agent. It's called adnexanet alpha. and it's given by a bolus and 2-hour infusion. And they did a very difficult study. They took patients who were having active serious bleeds and had recently received a dose of a DOAC within 18 hours. About 2/3 of these patients had an intracranial hemorrhage on a DOAC, and specifically a 10A inhibitor here. And most of the remaining had active GI bleeding. And hard to do a randomized trial in this group, so they gave everybody the reversal agent, bolus plus 2-hour infusion, and then they measured anticoagulant effect and said, did this drug actually reverse the anticoagulation levels or effect? And was adequate hemostasis achieved as determined by the physician? So this slide shows you the pharmacodynamic data. Here's the anti-10A activity at baseline before they gave the antidote, and then you can see after the bolus and through the end of the infusion, there's almost no effect. Now, by hour 4, you're at the same levels you were at baseline. This may be a good thing or may be a bad thing. On the one hand, one could argue, you inhibit things for 4 hours, maybe the bleeding stops, you can do a surgery or whatever else you need to get done, and now the bleeding risk is lower. On the other hand, you might say, well, if the patient's having active ongoing GI bleeding, often that lasts more than 4 hours, so you may need to give additional dosing. But I think this was helpful. It shows reversal of the effect for both apixaban and rivaroxaban. There were a few patients on enoxaparin, not enough. The FDA didn't find it convincing. There were too few with edoxaban to be studied. Here are the results for whether adequate hemostasis was achieved. Please don't ask me to define it. It's a 3-page definition in the appendix to the paper. You can find it there. But basically, they asked the docs, look, did the bleeding stop, or at least did it slow down to a degree that it made you comfortable? For intracranial bleeding, they repeated CT scans to look at the size of the bleed, whether it had stopped or whether it continued to grow rapidly. For GI bleeding, they looked at things like, did you have to continue to give transfusions? Did the hemoglobin continue to decline after the infusion? So 82% had good or excellent or good hemostasis achieved. It was similar for the 2 10A inhibitor studied and similar in major subgroups. This is a high-risk situation. Remember, almost 2/3 had intracranial hemorrhage, so that 14% died at 30 days and 10% had thrombosis. Not thrombosis immediately while the infusion was going in. It's not that kind. It's that in the days to weeks afterwards, when you're withholding anticoagulation, these patients are at risk for bad events. The second paper I wanted to share with you comes again from McMaster, and they looked at the reversal of dabigatran with idiracizumab, the antidote, the antibody, and they broke it down into patients who had severe, moderate, mild, or normal renal function. Now, if a patient had mild or normal renal function, you give the antidote, there's no anticoagulant effect out to 24 hours. You're done. Patients had severe renal dysfunction. You can see that the dabigatran concentrations actually become measurable at 12 hours, and by 24 hours, you're starting to see a fair amount of dabigatran reappearing in the blood. Well, why is that? Well, if you have severe renal dysfunction and you have a drug that's 80% renally cleared, I mean, initially you give the antidote, the antibody, it binds up the drug, that's cleared. But then there's some residual dabigatran that's still in the system or coming in from the extravascular space, and then there's no more antibody around. So you may need, in patients with severe renal insufficiency, to give a second dose at 12 to 24 hours. Less of an issue with moderate. I don't know that this is going to be important. One of the folks I met during the journey through the ENGAGE-AF trial was an investigator from Korea, very ambitious young guy, Sun-Hyun Park, who manages a lot of patients with hypertension. That's his area within cardiology, and he wanted to know what blood pressure should we aim for in our patients with atrial fibrillation, right? In Asia and Korea, lots of issues with hypertension, maybe salt in the diet or genetics, what have you. And what we did here is an adjusted analysis where we took the average blood pressure during this trial that lasted about almost 3 years and ENGAGE, and we categorized patients by their average blood pressure and found that for prevention of stroke or systemic embolism, the optimal blood pressure range was a systolic of 110 to 120. few patients average less than 110, but they seem to do well, and that we could see a stroke risk that increased significantly as the systolic blood pressure rose above 120. For major bleeding, that cut point was about 140. That's where your risk of major bleeding increased. So this supports current guideline recommendations to aim for a blood pressure of 120 or even less, and that for stroke, you can start to see increases above that. I also asked him, I said, that's fine, but now we have a randomized trial, so wouldn't it be interesting to look at patients' efficacy of edoxaban relative to warfarin and safety across different ranges of blood pressure? And I'm not going to go through it in detail, but basically there's no significant interaction, meaning the efficacy of edoxaban is the same regardless of what blood pressure the patient has, and the safety is also good and favorable with edoxaban compared to warfarin across the range of blood pressures. A second paper, and these are really new, the paper has just been accepted actually in publication, so you can't find it, is an analysis of diabetes. So this is a fellow who I've been mentoring since she was a medical student at Harvard, fellow at Mount Sinai, who's interested in diabetes and the overlap with atrial fibrillation. A lot of interesting work being done in that area. And she asked a question, she said, I'm wondering just what is the independent contribution of diabetes to the risk of stroke and bleeding and other cardiovascular events? And as we know, diabetics are complex. They often have many other comorbidities, dyslipidemia, type 2 diabetics tend to be obese, right? And you've got a lot of other baggage that travels with the diabetes. And what we found is when we adjusted for all the other differences and just focused on the effect of diabetes, there was a very modest increased risk in stroke or systemic embolism that wasn't statistically significant, but there was about a 25 to 30% relative increased risk in cardiovascular death, MACE, so major adverse cardiac events, major bleeding, or the net outcome that we could attribute just to the diabetes. The second part of our work was then to look at how edoxaban fared in diabetics, and because again we had pharmacokinetics and pharmacodynamics, we looked at concentrations and 10A activity measured at different trough and at peak in different measures, and we basically found that numerically the results were quite similar. Some of these, yes, are statistically different, but I would point out that these are really of uncertain clinical significance. I mean, the numbers are very similar. We have thousands of patients, so one needs to interpret what it means to have a very similar rate, but numerically perhaps statistically different. But my takeaway from here is that the drug PK/PD effects were similar. And so knowing that, you wouldn't be surprised to see that the outcomes in diabetics and non-diabetics were similar to the overall population. And that was true of stroke and systemic embolism as well as major bleeding, and we looked at cardiovascular death and the net outcome. Now, what's not yet published, and in fact, we're working on this right now, I hope to have this done in the first quarter of this year, is a meta-analysis, because we had the data on edoxaban, not yet in press, and the others had written their data up with apixaban, dabigatran, and rivaroxaban. So for stroke or systemic embolism, in patient with diabetes, the DOACs are a winner. They reduce stroke or systemic embolism about 20% in diabetic patients across these trials. And you can see that, there are a large number of patients here, 15, 16,000 or more with diabetes in the trials. In non-diabetics, it's similar. Interestingly, major bleeding in diabetics is similar between the DOACs and warfarin. Edoxaban, for whatever reason, had a significant reduction in major bleeding amongst the diabetics. The others were all very similar to warfarin. In non-diabetics, apixaban had a strong signal for reduction in bleeding. So this is work that's in progress from our group, and we'll see where it's going to go. So I need to talk cover in these last few minutes, and I do want to save some time about dosing. Selecting the dose is key with an anticoagulant, right? It's mostly about dose here, because you get the dose wrong, you could either end up in a situation of excess bleeding or a situation where you don't protect the patient from thrombosis. It's complicated. You need to consider age, weight. I have some data that suggests race is important as well. Renal function, what other medicines they're on. etc. So it becomes complicated. But I want to share with you one important thing, and that is get the dose right. So these data from Europe, and there are similar data from the US, suggest that in clinical practice, we're using too much of the reduced doses without adequate justification. So here's our data from 5 European countries. Apixaban 2.5 milligrams, where you remember was administered to fewer 5% of the patients in the Aristotle trial, is being administered anywhere between 34 and 44% of the patients in these European countries are getting the reduced dose. Now, I expect the number not to be 5% like it was in the trial, because patients in practice often wouldn't qualify for a trial. I'm not sure I would have expected to be 8 times what was seen in the trial. There are similar data but less extreme for rivaroxaban and edoxaban, where the rates are 1.5 to 2-fold higher than was seen in the trial. Dabigatran, of course, it was a randomized comparison of 110 and 150. This data just suggests that most people in Europe are gravitating towards the lower dose at about a 55-45 split. So is it important if we get the dose wrong? Well, these data from the US, almost 15,000 patients, show that you can get into trouble if you don't get the dose right. It turned out that 1 in 6 patients had the wrong dose, were receiving the improper dose according to the prescribing information, that 3/4 of the time it was underdosed, or 12% were being underdosed of the entire population studied here, and 4% were being overdosed. And if you're overdosed, the risk of major bleeding increases by more than 2-fold. And if you're underdosed, and there were only enough data with apixaban in this analysis, if you're underdosed, the risk of stroke or systemic embolism was almost 5-fold higher. Now, I think this makes intuitive sense. I don't know if numerically, because this is not a randomized comparison, so this is using propensity matching, if I believe the numeric results, but certainly the direction makes sense, and this really underscores the importance of getting the dose right. I want to end then with my kind of summary. When I gave a similar talk in December at McMaster, Salim Youssef, who gets it like right away, gets to the point, he says, "Bob, you've shown us a lot of data, it's wonderful, but for the practicing clinician, they can't hold all these facts in their brain, so can you just summarize it?" So here's what my approach, and this is what I think the take-home message ought to be, is to select the right DOAC for the patient and also get the dose right. So if they're high risk of bleeding, I like apixaban or edoxaban. In the States, we don't have DABI 110, but I think that would be a reasonable option. Previous GI bleeding, I think you could go with apixaban, the reduced dose dabigatran, which has less of that GI bleed signal, or edoxaban 30. If the patient qualifies for dose reduction, the hazard ratio for GI bleeding is about 1.0 for the low dose. In renal impairment, I think the winners are apixaban or edoxaban. I didn't have time to show you the data, but both those drugs reduce bleeding in the renally impaired and preserve efficacy. Remember, cytochrome P450 inhibitors interact with apixaban and rivaroxaban, so I'd be cautious about that, particularly rivaroxaban. In liver disease, we have data we've published with edoxaban. Dabigatran's 80% renally cleared, so how much is cleared by the liver? Probably 20% or less, right? So maybe a reasonable choice, although there aren't lots of data there. Ischemic stroke, I mentioned earlier, I like dabigatran 150, particularly in younger patients, low bleeding profile, normal renal function. In coronary disease, complicated issue, many trials generally underpowered. I think you could use any of the DOACs. The question is, what is the right dose? And more importantly, how long and which antiplatelets do you use? And do you use 1 or 2, and when do you drop it, and so forth? And that still is an area that's in evolution, although in Canada and Europe, the guidelines are moving towards shorter use of triple therapy on the order of days to weeks, using dual therapy, meaning a single antiplatelet and a DOAC, out to a year, and then just anticoagulant alone after a year. And then patient preference, if it's important to a patient, the 2 once-daily options are edoxaban and rivaroxaban. So I think I ought to end here so we could have a few moments for questions. Thank you all for coming today, and I hope you found this useful. Thank you.